This program is brought to you by Emory University.
Good morning, everyone. Happy Friday. Thank you so much for coming to our Fellows Conference this morning. This morning, we have Dr. Jeffrey Wang, who is one of our fellows who was on the academic clinical investigator pathway. He did his medical school at LSU and then internal medicine training at Johns Hopkins, and then a year of critical care fellowship at the NIH. And he's going to be staying in Atlanta next year, and we'll be doing critical care cardiology. And today he's going to be talking to us about two recent publications regarding shock, and he'll be presenting them both back to back. So save your questions for the first journal article, and we can discuss them all afterwards.
Thank you,
Jeff, take
Dr.
it away.
Thank you, Dr. Coley, and appreciate everyone's time this morning. So I'll be presenting two journals, a report from the Cardiogenic Shock Working Group, which is based in Tufts, and then Alt-Shock 2, which was a randomized clinical trial that was presented at ACC this past a few weeks ago. So the first paper is Serial Shock Severity Assessment within 72 hours of diagnosis, a Cardiogenic Shock Working Group report. So for this presentation, what I'll do is briefly go over cardiogenic shock, review sky staging, because that was a big methods approach in this paper, talk about the methods they used, the results, and then discussion points. And I have three short discussion points I think would be interesting. We can talk about them as we said at the end. So cardiogenic shock, it's a very simple concept. It's just pump failure. However, it's been very difficult to define. And I usually just like to put this out here because it's what Dr. Hockman used in her initial shock trial in 2001. And it's basically defined as systolic blood pressure less than 90 for at least 30 minutes, or you need inotropes or devices to maintain a normal mean arterial blood pressure. You have evidence of impaired perfusion, whether it's through cold extremities, altered mental status, low urine output, and then you have to be able to blame it on the heart, meaning the cardiac index is at least less than 2.2. And then most places would put a wedge at least 15, but I just kind of, for brevity, take that out there. So cardiogenic shock is also now being subphenotyped into AMI and heart failure. And so AMI meaning acute myocardial infarction cardiogenic shock versus heart failure cardiogenic shock. And the presentations of both of these are generally pretty different, where AMI, you go straight from ambulatory to moribund versus heart failure cardiogenic shock, where you have supposedly over years of deterioration before you ended up in cardiogenic shock. And then overall, the outcomes in these two types of patients, AMI and heart failure, are a little different. And so there's this paper by Dr. Sinha, which showed that patients with AMI were usually sicker with more vasopressors, whereas patients with heart failure cardiogenic shock sort of had a lower 1-year mortality. But then they did find that if both patients could make it to discharge, that the mortality post-discharge was very similar. So another way to characterize cardiogenic shock besides the etiology is also the SCAI classification, which is what the paper I'm presenting first today is really based on. And so this was put out in 2019, and then it was updated in 2021, the SCAI classification. And I think that most people in this room are familiar with it, but just to review. So people who are A, at risk, means that you come in with some sort of cardiac insult, whether it's acute decompensated heart failure or AMI, but you have no evidence of shock, but you are what they call at risk. B is defined as beginning cardiogenic shock, where you have some hypotension, some tachycardia, and at least in the SCAI 2021 update, they said that your lactate had to be normal. Your urine output may drop a little bit and your BNP may be elevated, but you're not hypoperfusing. C is classic shock, so you are in shock. Your lactate's elevated, your creatinine, your BNP's up, and at this point, you're either requiring one inotrope or one device. D is you're getting worse despite the intervention. So it's like stage C, you started the butamine 5 and the lactate doesn't clear and the patient gets colder, the urine output gets even worse, the creatinine gets higher. And then E is really sort of the like the patients who are critically ill, they're definitely in the ICU and you're actively calling for, ECMO, sometimes they're even undergoing CPR. And so the SCAI classification has been validated in multiple studies here. This is a good review article, and it basically shows that your presenting SCAI classification does predict your mortality, as you would guess. But this paper focuses on not just the initial SCAI SCAI classification, but the serial SCAI assessments. And so there's been only a few papers where they looked at 24-hour sky changes, and the Italian alt shock registry here actually found that the 24-hour sky classification was more predictive than the admission sky classification. And then here, Dr. Jenser on the right side, using his Mayo CICU database, also found that people who had worsening sky classification generally did worse. And if you had an improving sky classification, then you did better. And if you and then unchanged is obviously in the middle. And so all these things are pretty much what you would expect from being a clinician at the bedside, seeing these patients either get better or deteriorate. So what's the knowledge gap? So basically, trajectories in cardiogenic shock beyond the first 24 hours have not been examined. And then we don't know which sky stage has the most change in 24 hours, and is there more change after 24 hours? Because the problem is that previous studies have only been limited to the first 24 hours. So this paper was using the cardiogenic shock working group, which is part of Dr. Naveen Kapoor's group. The other big registry out there is the C3TN, which Emory is actually a part of C3TN. So anyone who has any interest in C3TN, feel free to contact me and I can, get you involved. So the methods for this paper is that it's an international multi-center prospective registry. You can see all the centers highlighted here. Tufts is the data coordinating center. They looked at patients from 2021 to 2022, and they looked at all types of cardiogenic shock. They categorized them into heart failure cardiogenic shock, AMI cardiogenic shock, and basically other cardiogenic shock, valvular, acute myocarditis, other things that didn't fit into those two nice buckets. And then instead of just following a baseline in 24 hours, they went from 0, 24, 48, and 72. And the sky stage was determined based on hemodynamics, lactates, and TMCS. And the primary outcome was in-hospital mortality, and the sky stage was sort of the secondary outcome. One important thing to keep in mind is that, we've already gone over the triangle on the left, but the cardiogenic shock working group actually sort of modified their own sky stage criteria. And there's going to be a red box on the right side here, which I'll highlight for you, which showed that they actually added a lactate in for sky stage B. So sky stage B, we had previously discussed, was your lactate was normal, but for them, they actually said that sky stage B and C could be a lactate of 2 to 5. And so that, I think that has added a little bit of kind of made some nuance into this manuscript that I'll go into. So results. So they had 3,268 patients. Most of them were in heart failure cardiogenic shock, 57%. 27% were in AMI cardiogenic shock, and then the other was 16%. The typical patient was a white male in their 60s, and then heart failure cardiogenic shock had more comorbidities, whereas the MI cardiogenic shock had more out-of-hospital cardiac arrests. For AMI cardiogenic shock, these patients usually go from ambulatory to critically ill, so you would expect their lactates to be higher, meaning their bicarbs would be lower. Whereas heart failure cardiogenic shock, they have more time to sort of build up, volume overload, and so their ALT, their INR, and their pulmonary pressures were higher. The cardiac output and index were higher in the AMI cardiogenic shock, but that wasn't statistically significant. And then this one, this figure was a little hard for me to interpret when I first looked at it, so I had to kind of take some time with it. But on the left-hand side, they categorized it by AMI on the top and then heart failure cardiogenic shock on the bottom. And then on the top, they were looking at number of vasoactives, 0, 1, and 2 or more. And then on the right side, they're looking at devices as well. So we can start off with temporary mechanical circulatory support. And so basically at 0, which will be under right here, where my mouse is showing. Basically at 0, there was more patients getting TMCS and AMI cardiogenic shock compared to heart failure cardiogenic shock, which makes sense and matches what you see clinically. People who have acute myocardial infarction, cardiogenic shock, oftentimes go to the cath lab, where if they're critically ill, oftentimes, we'll put in some device, whether it's a balloon pump or a CP or 2.5. Whereas compared to heart failure cardiogenic shock, they had a little bit more vasoactives there. It's still about the same between AMI and heart failure, but there's more vasoactives in the heart failure in the heart failure group. And so you can see that there's more vasoactives there, and that makes sense because oftentimes these patients are also already on chronic inotropes and they come in on that as well. And then TMCS escalation from 0 to 24 was pretty high in the acute myocardial infarction cardiogenic shock group. So this is sort of the main figure, and I'll spend a little bit more time on it. And this is sort of why I think it's probably, in Journal of the American College of Cardiology. So what they found was that, as you can see, this is a alluvial diagram. And for people who haven't seen alluvial diagrams before, what the x-axis is 0, 24, 48, and 72. And then the y-axis is sort of what sky stage you are in. And then each line is one patient. And so they basically tracked all 3,268 patients across each timeline with one line. And thicker lines mean more patients, thinner lines mean less patients. So it's an alluvial diagram. And so you can see that in the first 24 hours that there is a lot of change. And so you can see that half of people in Sky B stay in B, and half of them deteriorate to either Sky C or D. And then in Sky C, about half of them get worse to D, and half of them stay in C or maybe a tiny bit get better. But you can see that the change is really in the first 24 hours. And after the first 24 hours, there really isn't that much change. And there is still some change between 24 to 48 and 48 to 72, but the biggest change is really in the first 24 hours. And so I think that's the kind of critical take-home point of this entire paper. There's other things too. So this one is a little bit of a confusing figure, but it's helpful. So in this population, so what they did was they looked at the sky stage at baseline right here on the left-hand side, and then basically they basically just kind of put them through. So it's another representation of the previous figure. And the main thing that I wanted to point out here was that what I put in red is the percent mortality. And you can see that at B, the mortality was 28%. At C, it went down to 22, and then D, 33.8, and E is 59.6. And I think that was one of the I don't want to say issues, but it didn't match what we found in literature, where all those beautiful graphs before showed sky A, B, C, D, E with progressing increasing mortality. It actually is higher in B, then goes down in C, and then goes back up in D and E. And the authors did note that, and I'll just kind of read what they said. The inclusion of low lactate levels was meant to raise clinicians' awareness of the prompt nature of cardiogenic shock and encourage prompt implementation of interventions. This likely led to inclusion of sicker stage B patients with hyperperfusion and explained the similar trajectories between stage B and stage C. So that was their explanation. This one is only showing the first 24 hours after from baseline to first 24 hours. So basically, these are patients who started off in stage B, and then at 24 hours, they either remained in stage B or worsened to C, D, or E. And so this shows only the sky stage at 24 hours. And I think there's a lot of ways we can slice and dice this data, but the main take-home points that the authors, and I think is reasonable to bring up, is that mortality is highest when patients progress or stays in sky stage E. And so you can see that mortality, that if you're in sky E at 24 hours, your mortality is between 50 and 80%, which makes sense because you're in extremis. And then finally, the other point that they wanted to make was that if you're, regardless of how you got there, whether you started off in B or if you started off in C, if you ended up in sky stage C at 24 hours, your mortality was unchanged. And so they're saying that if you were at B, then you went to C, your mortality was 25%. If you were in C and you stayed in C, your mortality was 15.8%. And they're saying that that was the same based on the chi-square. It was 0.1 for P 0.1. 25 to 15 seems like a pretty big difference to me, at least, and I don't know if it's underpowered, but this is one of the points they wanted to make. Another point they wanted to make was that it wasn't easy to predict who was going to stabilize or worsen, and so basically patients who came in they looked at differences, whether they worsened their sky stage or their sky stage stabilized. And there wasn't really, the baseline characteristics were pretty similar between the two groups. One thing they didn't mention was whether, for example, whether the underlying condition was corrected. I didn't see that as like a variable they necessarily adjusted for, or they mentioned. For example, if they had a STEMI, did they get like a stent in time? And I think those factors are obviously very important, but it at least just wasn't mentioned in the main manuscript or the supplement. And the only thing that they found was that the lactate and the age predicted survival. And so you can see that within each group, they looked at the mean lactate levels between survivors and non-survivors. And as you would guess, non-survivors had higher lactate levels. And then between survivors and non-survivors, survivors were younger than non-survivors. So to wrap up this presentation, this first journal, so does this change clinical practice? I think that this is a very important manuscript for critical care cardiology, and it's useful to um, to 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 use the data and to understand our data. But I think for the astute clinician who is in the CICU frequently, I don't think that this changes anything too much, because I think anyone who's even stepped foot in the CICU for one day realizes that cardiogenic shock patients are dynamic and they should undergo frequent assessments for clinical improvement or worsening. And what you see at the bedside should prompt whether you escalate or de-escalate care. The only thing I think this changes is that the first 24 hours are very critical, and they're probably a little bit more important than the subsequent 24 to 48 hours. But the first 24 hours, I think that their initial, how sick you think the patient is can change very quickly. Point two, why is mortality Sky B greater than Sky C? I kind of already went over this earlier and said that, it's because the cardiogenic shock working group included lactate 2 to 5 in Sky Stage B. And so based on their definition, you could be pretty sick and stay in Sky Stage B. You could be hypoperfused. Third point, and I think this one would be a little bit more interesting for discussion, is that, how do we best use the CICU, especially at Clifton, where, that's limited to 21 beds, and Midtown is limited to 14 beds. There's always a wait list to get in. And so, when you think about what the purpose of an ICU is, it's not only to provide like critically ill patients with care, it's really to identify and provide the right care to the right patient at the right time. And so, the question is, the patients I think that most benefit from CICU are the patients who we can predict, or maybe not predict, but have a high suspicion that they're deteriorating from B to C to D, and they need urgent intervention. And, the question about, the Sky Stage C patients who are stable on, Impella 5.5 or dobutamine 5, do they necessarily need to stay in the ICU? We have patients on inotrope that are stably on the floor all the time. We obviously don't have patients in the Impella on the floor, but interestingly enough and timely enough, there was a recent publication by Dr. Carnicelli at MUSC where they actually made like an Impella step-down unit. And so what they did was they put an Impella in, and then they monitor them for a certain amount of time, and then if they met clinical stability, they actually transfer them out of the CVICU. I'm not saying that's what we need to do. I'm just saying that this is what an interesting idea to make the use of CICU beds, and also, this is an implication of what it means to change Sky classification. So, in summary, this paper was the first large multi-center prospective registry to follow cardiogenic shock patients over the first 72 hours. More than 50% of the patients in Sky B or C progressed to worse Sky stage within the first 24 hours. And if a patient's cardiogenic shock status changed, it was most likely to happen in the first 24 hours. And then, at least what the paper wanted to posit was that the mortality was similar between if you went from B to C versus unchanged at C. And then the initial age and lactate was predictive of mortality in the regardless of Sky stage classification. So this next one I saw at ACC was really, really cool. I was hopeful, but so early intra-aortic balloon support for heart failure related cardiogenic shock, ALT-2 shock trial. And so they basically, the title says it all. And so what I'll do in this one is just quickly review IABP hemodynamics background, kind of quickly go over the idea of what an IABP super responder is, discuss the methods, results, and then discussion. So IABP, we're familiar with it. it deflates during systole and it inflates during diastole. And there's, a couple of things that it does, but the first one is improve coronary perfusion pressure because it augments during diastole. And then the things during systole that it would help is that because the balloon deflates during systole, it'll reduce afterload. And the term that people like to use is it improves ventriculo-arterial coupling. And then finally, the last thing is that if you improve LV emptying, you actually even reduce the LV preload as well, so you can kind of decongest. So these effects aren't just theoretical. This is a paper by Dr. Su, and he basically, put in balloon pumps, put in PA catheters and balloon pumps, and then monitor these patients and showed that in fact does happen. Like preload does drop, afterload does drop, and LV contractility does improve. So this, isn't news to anyone, but the European people have tried this in AMI cardiogenic shock, and theoretically, the most benefit you would get from an IABP is in myocardial infarction cardiogenic shock because there you have impaired coronary perfusion and you have impaired hemodynamics. So theoretically, the balloon pump targets both of those, and this is where you should get the most effect. However, the IABP Shock 2 trial published by Dr. Thiele showed that there is no difference in this group, and this has led to a ESC ACS 2018 guidelines giving it a 3B. And up until recently, the Americans actually gave it like a 2A or 2B, but I'll show you that. I already showed this slide earlier, just talking about the two different types of cardiogenic shock. And so we've kind of said AMI cardiogenic shock, routine use, there's no benefit in routine use of intra-aortic balloon pump, but what about the heart failure cardiogenic shock people? And so this is a paper from the cardiogenic shock working group, same group that published the first paper, and they looked at the amount of MCS that was being used in heart failure cardiogenic shock. And you can see that even though there's no randomized clinical trial data showing that IABP works, IABP use is still very highly prevalent, like high prevalence in use in this population. So, the hypothesis of why this would be is that, maybe it's more the hemodynamic effects of the balloon pump that's important, the afterload reducing effects, the preload reducing effects. And that could make sense because in heart failure, the patient's EF is extremely low and they're very afterload sensitive. And so you could guess that, the hemodynamic effects of the intra-aortic balloon pump are what's doing the benefit. So I put two figures from two different actually yeah just one paper here. So here this is a group up in Colombia, and what they did was they looked at the hemodynamics with PA catheters in patients with AMI cardiogenic shock and acute decompensated heart failure or heart failure cardiogenic shock, and essentially they found that in AMI cardiogenic shock that you have as many non-responders or people who actually do worse compared to people who actually do better. And so this could explain why in IABP Shock 2 you didn't really see anything, because if you look at all comers, you're making people's output lower as often as you're making it higher, therefore having a net effect of 0. But they did find that in heart failure cardiogenic shock that there was more net benefit higher than there was lower. And so you were making some people's output lower, but in general you were making people's higher. And then they did a follow-up study here where they essentially did the same thing, but then they sort of identified sort of like super responders, which they identify as people with the increase in cardio output of 1 liter or more. And I do think that anecdotally, we see that some people get this really robust response from IABP and some people don't. And there's no literature yet published on exactly what will predict someone's response to intra-aortic balloon pump. And I know that a lot of us will have anecdotal experiences and clinical judgment, but it hasn't been published in papers and hasn't been widely validated. And obviously, there's no positive randomized clinical trial yet. So, shocker, there is a update in the AHA-ACC acute coronary syndrome guidelines, and the Americans have now joined the Europeans and said that in AMI cardiogenic shock, routine use of intra-aortic balloon pump is not recommended, and also to my dismay, VA ECMO as well. But so it used to be like a 2A, but now they've sort of said that routine use. So And what they're not saying is you can't ever use it. You just can't use it routinely for all. You have to think about it and sort of justify why you think this patient really does need a balloon pump. Putting in routinely for all these patients is not recommended by AHA ACC guidelines now. So I do think that this is really timely and for the trial to come out. And so where does this kind of leave us? So uh, who should we be using the intra-aortic balloon pump in? I think that as someone as cardiologists who work in CICU, I think that it's really clear that if you're in sky stage E, you're too sick, and a balloon pump's not going to do anything for you. And if you're in sky stage A and maybe like early B, you're probably too well, and you just don't need an intra-aortic balloon pump, and you'll probably develop complications from it and derive no benefit. And so between sky stage D, C, and maybe like B going into C, the population to use the balloon pump is somewhere in there, and also the patient characteristics that we have to identify are somewhere in there too, and we just don't know what it is. So this is what this paper tried to answer. So AltShock 2, it's an Italian trial. They are multi-center network with 17 sites, and they enrolled patients in the peak of COVID from June 2020 to October 2024. And the criteria was heart failure, cardiogenic shock, and the age was 18 to 75. 75 was the cutoff because that's their age limit for doing heart transplants. And they initially wanted to include only Stage C, but due to low enrollment, they amended it to Sky Stage B, and the primary outcome was 60-day survival or bridge transplant. And one thing to note is that they screened 787 patients and excluded 686, meaning that out of the initial 787, only 100 patients ended up getting randomized, and 48 of those went to no balloon pump, and 53 of them went to the balloon pump arm. So baseline characteristics, it was generally a male in his 60s with a BMI of 25. The LVEF was generally very depressed, around 20%. And the patients generally had a blood pressure of 90s to 50s, and their lactate was interestingly pretty low at 1.8, and most were sky stage C, so about 50% of them were sky stage C, and then sky stage B was around 20 to 30%, and D was about 13 to 19%. Approximately two-thirds of the patients were on inotrope, so about a third of them weren't on any support at all. And then only for 40% of the patients had invasive monitoring, meaning a PA catheter. And that was in the discussion that was considered a limitation of the trial because they weren't able to monitor the effects of what they did. One thing the authors should be commended for is that they enroll these patients very quickly after arrival to the hospital and to the CCU. So the Data Safety Monitoring Board terminated the trial on October 9th, 2024, because of futility, because even if the balloon pump were to work in the last 100 projected enrollment of patients, it wouldn't have changed the outcome. And so in the no IABP arm, the survival was 75%, and then in the IABP arm, the survival was 81%, 43 over 53. One thing to note is that there was a high survival in this cohort compared to other cardiogenic shock groups, and part of it may be that they primarily enrolled Sky Stage C and B, which obviously is higher survival compared to all comers. They also did a bunch of subgroup analyses, and none of the interactions were significant. So they looked at higher lower blood pressure, higher lower lactate, age differences. They even looked at Sky Stage B as well, and compared to C and D. And you can sort of make some murmurings about the tea leaves, but nothing was very significant. And then regarding secondary outpoints such as duration of hospitalization, SOFA score, inotropic score, none of these things were different. And one thing that the authors didn't want to note is that there's really no statistically significant increase in vascular complications and bleeding complications and limb ischemia with intra-aortic balloon pump. Number one, it could be underpowered, but the sheath we put in is 8 French, so it's small, relatively small, and so the risk of a balloon pump is not as it's not very high. There still is a risk, just not very high. So the question I think everyone wanted to figure out was, why did these patients not improve their outcomes with intra-aortic balloon pump? And so one of the hypotheses was these patients may have been too well to benefit. And so Sky Stage B may be too well to benefit. Only two-thirds of the patients were on inotropes, and the average lactate was 1.8 to 2. And so, anecdotally, I think sometimes when we uh, want to quote unquote rescue these patients. It might be people who are B sliding into C, or maybe C and not responding well to the first line therapy, maybe inotrope, and then that's where IABP can come from. But people who are sort of in Sky Stage B or stably in C may not benefit much from a balloon pump. Also, the thing that I keep bringing up is that we still don't know who are the super responders for the intra-aortic balloon pump. What are the patient characteristics that will make someone have an augmentation of greater than 1 liter per minute? And so this was from an editorial, and I thought it was pretty good. They basically have talked about, what is the role for intra-aortic balloon pump? And so the first heart here on the left is AMI cardiogenic shock. IABP shock 2 said that routine use is not good for that. Heart failure cardiogenic shock. We don't have any randomized clinical trial up until now for the alt shock 2, but is this trial going to be enough to push it from a 2A to a 3B? And then the other two uses for intra-aortic balloon pump is, mechanical complications, whether it's like acute mitral regurgitation or VSD, sometimes can still be used for that. And then finally, instead of, ECPella, some people do VA ECMO and intra-aortic balloon pump for unloading. And so those are the remaining two that still patients can still get the intra-aortic balloon pump for, and there's not randomized clinical trial data advocating against routine use of that. So I think, how does this impact clinical practice? So, at the end of the day, all these guidelines talk about routine use. And so, I think that as clinicians, you can still make individual judgments on and treat the patient at the bedside and say that this patient will benefit. But I do think that we should be thinking twice instead of reflexively saying balloon pump is the answer. All right. Thank you for your time. I appreciate everyone's time. I know it's always hectic first thing early in the morning.
Thanks, Jeff. That was a really nice review of those two articles. Before I open up the floor to questions, I'm curious, like how you're gonna, you're about to be a critical care attending, how you're gonna integrate this data into your practice.
Yeah, that's a great question. So, I think that for the cardiogenic shock working group trial, I think that um, you know, like nothing ever substitutes for being at the bedside, and I think that's especially true for cardiogenic shock. And so, I think that in the first 24 hours, I will just want to be as present as possible until I develop my own spidey senses on which way things will go. But I think that this really illustrates to me the importance of just being present for the first 24 hours. That's the first paper. The second paper, I think that um, I don't know how it's going to impact what I do because I think there's a lot of people with far more experience than me, and I'll probably lean on them heavily more. But I do think it brings up a lot of interesting, like potential future research questions and future directions. And if anything, it helps us select our patient population. And I kind of look at it as with all the other MCS trials that have been positive or negative. The ECLS shock trial where they did VA ECMO and cardiogenic shock in Europe, it was a negative trial. And then danger shock was positive, and then this one is negative. And I think that a lot of it comes back to patient selection. And I think that, in the future, if I ever get involved in these type of projects, it really does reinforce to me that you really have to be careful of who you're selecting because these devices have a lot of pros and a lot of negatives as well. And so you really have to make sure that you're helping more people than you're hurting. And that's why I think that this paper to me really just goes back to patient selection. Thank you.
Great. Thanks for your observations. I'll open up the floor to any questions for our presenter today.
Oh, good morning. This is Dan Ram. Thank you, Priya. And Jeff, that's a great presentation. So I've had interest in this area for quite a while, but I think the most important thing in AMI cardiogenic shock is revascularization. Revascularize as soon as you can. And therefore, in the guidelines, we gave that a class 1 recommendation to revascularize as soon as you can. There's nothing better than revasculate the patient. Secondly, the concept we put up some years ago about levels of care I think the average time to transfer in a place like Clifton is 2.5 days, and nationally is 2.5 days. So
Yes.
think about somebody in rural Georgia who's young in the 25 to in the correct age group for myocardial shock, who has shock. His transfer time is really delayed, and therefore the mortality for people coming from out of town is extremely high, 3 times as much as in the city. So trying to get the right patient in the right place is very, very important. And the first 24 hours is very, very, very important, as you pointed out. So what can we do to make it better? And I think that, in the Danish shock trial, if we did not put the device in before the cupped vessel revascularization, the average time for impella placement there was about 4 hours, and therefore the benefit anything longer. So if you put a balloon pump in a hospital which can do private PCI, and it only has a balloon pump, there's no real benefit because if you even put the balloon pump in, by the time you transfer the patient, that window of opportunity that was seen in danger shock, about 4 hours so is gone. So after 24 hours, really the game is over.
Mm-hmm.
And from the FIT STEMI trial, every 10-minute delay after 90 minutes or so, the mortality was about four patients would die.
4%.
So revascularization and AMI cardiogenic shock, it's very, very important and appropriate case selection of the right person. Now, how do you handle cases that are outside places like Clifton? And in USC, for example, in LA, they have mobile teams of an interventionalist, a APP, and a nurse who go take your Impella device to smaller community hospital where the patient might be there with AMI cardiogenic shock and actually put the device there. And because the transfer times are greatly are high in that area too, and it takes hours for patients to get into USC. So we have to think about something about mobile units to help. But the main problem where we'll have the highest death is still people transferring into us. And not only Metro Atlanta has a lot of hospitals, but I think rural communities' death rate is very high. Finally, comment about what we put in our guidelines was the class 2 recommendation. If you talk to the trialists, like Holger and others, and talk to trialists who the balloon pump trials and the ECMO trials, there really is no benefit in these trials. When you say these are trial patients only, they're pre-selected for bias maybe, but the whole idea that and I've had this experience transferring patients from Decatur that I have somebody in Impella 3.5 and I really think they do better with escalation to 5.5, and I send them over and they get an ECMO put in without any data to support that. So you've got to follow the science and ECMO really has proliferated in this country without any real benefit. So if you look at all the trials, you talk to the trialists, and we had lots and lots of discussion with Holger and Jacob about their trials and looked at every piecemeal thing. We thought very hard before we put that to get class 2 recommendation. Really, the balloon pump or the ECMO has really no benefit in acute myocardial shock unless you pre-select this patient. Now, if you have over 24 hours and you're putting these devices in, they're not going to do better. So if you look at patients with class SCI A or B, somebody with a large anterior infarct, proximal lesion, EDP is 30, not quite there in class C, maybe that's the person that would benefit, okay? And we don't have any data to say, okay, if you have a center that does primary PCI, just has a balloon pump, but not an Impella, you put a balloon pump in, is there a downside putting it in before you send it to a center which takes care of advanced heart failure? No data support that. Nobody has that answer. Even the Henry Ford group with the NCSI data had patients transferring from the level 2 to Henry Ford, and there were mixed results from that group. So identifying the correct patient and act on the first 24 hours and get patients in as quickly as you can. 2.5 days of transfer means definite death for that patient. And that's the only comments I have to suggest to you.
Yeah, thank you so much, Dr. Rob. I think that's all excellent points, and exactly what we should be working towards as a system is try to expedite these patients and like provide the right care to the right patient at the right time immediately. And then thank you for your insights about the guidelines too. Thank you. I think Dr. Abdu has a question.
Actually, more than a question, it's just a comment. First, great congratulations on a great presentation of two good articles.
Thank you.
And congratulations on almost approaching the finish line. So that's great. I'm excited for you and your career path. Very due. Now, it's not a question. It's more of like a comment. And my comment comes from, it's not very elegantly said like you with data and all that. It's all based on experience and anecdotal data. But here's the thing. These days, cardiogenic shock research and trials are amongst the most elegant research ongoing right now, in my opinion. I think it's beautiful. It's great. A lot of data is coming, a lot of encouragement. There's a lot of momentum. However, one thing that I don't want to call the criticism to the research, but the messages that sometimes these papers come out with, I don't want, especially for our junior fellows who are or the senior fellows who are about to be junior cardiologists and attendings, is to look at cardiogenic shock as a one dimension type of disease or presentation or syndrome. If you look at the cardiogenic shock work group, I know some of the people who are there personally. For example, I was just going to give an example. They heavily rely on, for example, lactic acid and the lactate levels, and that's what it is, and that's the determination of perfusion. And if your lactate is good, the life is beautiful. I don't think it's only that. It's more to than that. I'm not saying that's what they are advertising or that's what they're recommending only, but some of the papers are, when you read only one paper, that's what you kind of get to. So the most important message I have is when it comes to cardiogenic shock especially, you have to take the patient in wholesome, a holistic view of where the perfusion status of this patient is. Lactate acid and lactate levels are one parameter of that. Other parameters are many, and we can spend time after time talking about these parameters. So that's the main thing. The other thing is the question, like Dr. Rab just mentioned, is the data around the platform of support that we use. And it will take time to identify data-driven evidence of what to use and when to use and what's the optimal time. What you presented in the first paper is things that we kind of knew about, to just practicing in the ICU. But now we put it in a nice paper, which is really well written, and I loved it a lot, especially when I read it after it came out. So think about those things. Every patient and the setting that you're practicing in. There's a lot of more work to be done in our state, in our city, and more so in the nation, in order to improve care for these very ill patients, which still carry a lot of mortality even now with all this advancements in technology and so on and so forth. So good job. Always think about your patient in wholesome. Look at everything that relates to perfusion, your kidney function, your liver function, your CBC, how many pressors you're on, how is the patient doing at the bedside. I loved your comment about I want to be at the bedside in the first 24 hours. You're absolutely right. That's really, really important. Having eyes there and action, not more just eyes, but you have to act and act fast in those first critical 12 to 24 hours, I think is very, very important. So thank you and good luck with everything.
Thank you so much, Dr. Abdou. Great comments. I think Dr. Dickert has his hand up.
Yeah, thanks so much, Jeff. This is really helpful to go through. I think you did a nice job sort of accentuating both what we've learned and what we haven't learned. I think I would reiterate one of the points you made, which is I just think really, really important, especially in the acute MI shock population, that that patient over the first 24 hours may be very, very different. I mean, the number of times we have anterior MIs come in and they look great when they show up in the CCU, and then they're on mechanical support, 24 hours later we can all count a lot of examples of that. And I think that's just a really important point for our fellows and residents, that, that is a really dynamic period and we can make a difference. The second piece is, I guess I would say, it's sort of a big picture comment, but I think you alluded to it. The number of times we have these trials that are done, and we all wind up saying, but it didn't answer the question for the population and for the patient in front of me, is humbling, but not not surprising, right? I mean, these patients sort of trickle through, but for all of us who live in this world, you see them a lot, right? You think about submassive PE and how long it's taking us to try to sort of get everybody together to be able to do multi-center work to actually inform management. It's very similar, right? These are common to all of us, but they're not common from a trial perspective, right? They're not like our primary prevention CAD patients. It takes a lot of coordinated activities and a lot of work through networks like the 3CTN and others that I think do offer a potential platform for being able to do the right trial for the right patient population. I mean, the balloon pump trial is a perfect example for that, right? I mean, I don't know what others think, but my guess is you thought this. There's not a lot of interest in doing a trial of a balloon pump in heart failure, cardiogenic shock in patients who aren't on inotropes, right? Like that doesn't really answer the question that we struggle with. The other thing for all of these studies that's really tough is in many of these patients, the right outcome is not so much do you get them out of the hospital, off support. It's do we effectively bridge these folks to advanced therapies, right? And so the set of outcomes that are most meaningful has to include mechanical support, especially in the heart failure population. Mechanical support is not a sign of failure, or sorry, excuse me, transplant or LVAD. That's not a sign of failure. That's success if we get them there, right? And there's a lot of nuances in how to capture the right set of outcomes for all of these patients that I think it's not an easy population to study. I think there's a bit of a groundswell to try to do it, but we have to figure out how to kind of coordinate our efforts and do the right studies that actually inform care.
Yeah, that's a great point. And maybe one day, like the NIH, I know they're going through the struggles right now, but NIH sponsored the critical care trials and stuff like that, like the Pedal Network and ArtsNet. Maybe one day they can get into the critical care cardiology network somehow. Great. And then I saw Dr. Diamond had her hand up at one point. I don't know if you still want to say something.
Yeah, hey. I first want to say great presentation. This was excellent synthesizing these
Thank
two
you.
kind of complicated studies. Just a couple quick comments to kind of piggyback. The first is to really think about the audience of some of these. Having been in some of these conversations before, sometimes this kind of stuff is more geared at not our kind of like tertiary/quaternary CCUs, but more the general population CCUs where we usually get these patients from.
Makes
And,
sense.
thinking about even the sky stages, like you guys all know that, like we don't need to spell out what's the difference between stage A and C, A and E shock. And when you're presenting it, I was thinking like, oh, God, I never even think about these things except when I have to study for a test. But for other people, it probably is really useful because they don't see that kind of stuff all the time and need to be able to think in that way and then know what comes next. The other thing that struck me is actually this slide that you have showed right now, just, being the CCU attending right now and dealing with last night's events, like, even though it's not common, people change from B to, they go from B and C, but you can go from B to E really fast. And even though that's not everybody, to just keep in mind that like this is population level as opposed to patient by patient. And those are different approaches when you're actually the CCU attending. So to kind of rest on, oh, well, that doesn't happen very often because usually people go from B to C is not in reality what always happens. So I agree with Neil that you have to just be constantly reassessing and be at the bedside, like you said, and thinking about it without just resting on like heuristics and what generally happens. I just think it's important, to point that out. And then the last thing I was going to say is to piggyback on what Dr. Abdu said, that he's absolutely right, that just thinking about lactate and creatinine and just these couple of number values is not sufficient. And I remember, I was a cardiology fellow not too long ago, and as a first year fellow being signed out by my co-fellow, who interestingly writes a lot of papers now about hemodynamics, like, oh, this person's fine, their blood pressure's high. But this person had a lactate and we couldn't really figure out why. Well, it turns out they were in cardiogenic shock. They were just clamped down. And, I'll never forget that case because it took a little while to to realize that.
Diagnosis.
So, you know, and I've again been at a conversation where people were talking about these guidelines and someone was very vocal saying, you know, blood pressure shouldn't be in the guidelines. And I couldn't agree more. Like, I had to write a narrative for a transplant patient 2 weeks ago whose blood pressure is high and we're actually on antihypertensives, but they're definitely in shock. So just because their blood pressure is at 90 doesn't mean they're not in cardiogenic shock. It's just a different kind of phenotype. So to keep that in mind.
Perfect. Thank you so much for your comments, Dr. Diamond. We'll definitely keep those in mind. And then,
Hey Jeff, oh, is there anybody else that was there? I'm sorry, I couldn't do it on my phone. Go ahead.
oh yeah, thank you. Thank you very much. Oh, wait, did you have a question for us?
I
Or
just
no?
wanted to say exactly what Jamie said. This is for us, everybody, one of the CCU rounders. So yeah, I mean, you know, the cardiogenic shock work group did make that change of making the lactic acid elevated in B, you know, to raise awareness and all that. And I never understood that. Having said that, I think the more important thing was to, you know, I say that people do not have to be hypotensive to be in cardiogenic shock, because hypoperfusion is, you know, the actual hallmark of cardiogenic shock. And you know, making that change between B and C didn't, you know, muddy the water a little bit and kind of takes away the aspect of understanding that hypoperfusion, whether it's in, you know, renal flood dysfunction or liver enzymes going up or lactic acid going up, you know, just like Dr. Abdul was saying, you have to look at the patient at whole. But the blood pressure itself is not the, you know, the marker that tells you that a patient is doing okay, and you have to look at all the other aspects of that. So I absolutely agree with Dr. Diamond.
Thanks so much. And then, Dr. Rob, I saw your hand come back up again.
Yeah. So one of the things, we know we need to be aggressive first 24 hours, but after 24 hours, we really need to come down and find those patients who really won't do well. And, the automatic response and not putting ECMO in, and there's a overuse throughout this country of these devices placed on those patients who are just not going to survive. And the mortality is, close to 80% or more. And putting a device in at that time is not going to make a difference. So I think
True.
we have to, as a society, be conscious about the scope and limitation of these devices, the cost effectiveness and resource utilization, because somebody's not going to make it. Putting a device in is not the right thing to do. And I think you're going to tie up beds for no reason, people who can really benefit. But it's just like in cardiac arrest, we identified patients who really would not do well, and it's probably futile to bring them in. We have to have some kind of futility, score or recognition, where we have to tell families that the loved ones will just not survive despite what we do. And I think putting devices in and having them linger on for days is probably not the right thing to do at that point in time.
It's a really good point, and I agree. I mean, the amount of care sometimes we do, it can be a little daunting. And then let's see, Dr. Hollenberg. So great question. Oh yeah, go ahead. Did you?
Sorry, I can't figure out how to raise my hand on Zoom.
No
I'm
worries.
technically challenged, but so I'll say the question. I think both Neil is absolutely right, and you pointed this out too. There's a challenge. This is a really tough space to do studies in, and there's a challenge. So if you had a 20% mortality, which is what they wound up with, the question is whether anything would have worked. Do you really think an axial flow pump would have changed 20% to some significantly lower number, or ECMO or something else?
Yeah,
and
no, not yeah. Sorry, thank you. Yeah, not in this population. And actually, I actually had a chance to chat with the presenting author after her presentation. She was nice enough to sit down with me, and she was telling me that their expected effect size was higher and their expected mortality was higher. And so both the decreased effect of the balloon pump, which is nil, and the decreased mortality really made the DSMB just cut it early, because neither of those would have made any difference. And to answer your question, I don't think that this different, like, the mortality difference between these two groups are too small, that in order to detect any difference, you would probably need at least 1,000 patients or so. Does that answer your question?
Yeah, and I mean, just to be a little broader, there's now the debate about the Impella.
Yes.
The danger shock trial is a relatively narrow population of patients with acute MI shock who did not have cardiac arrest up front.
Yeah.
And you'll find people arguing that the devices should be confined to that group
Yeah.
and not really anything else. And those are where the trial data are now. It's not going to be so easy to get good trial data in other groups.
Agreed. No, that exactly. And I think that in the Dr. Thiele ECLS shock with VA ECMO, I think about 20 or 30% of his patients had out of hospital cardiac arrest. And so that could have been one of the reasons that maybe he didn't see much of a difference, because he was including all those patients that had cardiac arrest.
Yeah, I think I would just echo that you can dig deeper even than the ECLS shock, right? I mean, you look at Impress, you look at other. I mean, this field is like it's rich with trials that, for understandable reasons, have included patients who are either too sick to benefit or too well to benefit, and we all deal with that population in the middle, but it's been really hard to do the study that answers the right question for the right patient. And it's just tough. It's not because of poor intent. It's not because of anything other than this takes a really well-supported, coordinated effort and a lot of commitment on the part of the field to actually be willing to randomize in the right trial too.
Agreed. I couldn't agree more about, the patient selection. Perfect. Well, I don't see anyone else's hand up, and we're getting close to the top of the hour. I think we should be okay, Dr. Coley.
Yep. Thanks again, Jeff, for a great presentation, and everyone for a great discussion. And we will see everyone next Friday.
The preceding program is copyrighted by Emory University.